Not here. Then we will have our first speaker, our chairperson, Dr. Sonu Goel, who will be talking about FemtoLASIK basics.
A very good morning, and without wasting much of time, I thought Harshul would lay the stage with the basics of microkeratome flap making. So I've been asked to talk on the basics of FemtoLASIK by Vardhman. So a very brief initial picture of how the FemtoLASIK procedure works. So essentially we have this, it's basically the YAG laser operating in the infrared wavelength, and it produces these ultra short pulses of energy, and this creates ultra short pulses of energy, and this basically creates areas of microcavitation, and this essentially leads to separation of tissue at the molecular level and at a very specified depth of the cornea. So the bubbles which are created, they leave a cavitation bubble volume of around 2 to 3 cubic microns, and thousands of these tiny bubbles create in a raster pattern, and this is essentially what creates a cleavage plane, and this defines the interface between the flap and the stromal bed. So this is how the femtosecond laser actually works, and then you do an excimer ablation and keep the flap back. So essentially most of our practices have now actually shifted from microkeratome to femto-based flaps. So this is how we treat, and this is how I use the 800 platform. It takes essentially 5 seconds. You can center the flap, just watch carefully, and it is just a blink of an eye that this, once you dock, and this is how the flap is created. The laser system now moves free to inside, and then you have a side cut, and this is essentially the game for the flap creation. So this is how the main page of the VisuMax Smile 800 looks. So when you're talking of the flap with the femto platform, this is essentially a planar flap. So if you see here, vis-a-vis the meniscus shaped when you do a microkeratome based flap procedure. So what are actually the parameters which can be altered or they can be titrated when you're doing a femto-based platform? Now this is very, very important. These are the K readings which can be entered, the pachymetry. The treatment can be centered. So with the X and Y coordinates which can be taken on a topographer, the atlas very specifically here, the treatment can be centered right bang onto the visual axis. The flap can be taken on the visual axis. Then you have the refractive error, which doesn't essentially give you, not required. So the flap parameters which can actually be titrated vis-a-vis the microkeratome is the diameter of the flap here. You can have the thickness varying from as low as maybe 90 microns to whatever depth you want. The side cut angle, which is very, very important because this is one of the factors which helps in the epithelial ingrowth, can be titrated. You can have the hinge position which can be titrated. It could be a temporal or a superior or an inferior or a nasal hinges. So essentially we are talking here the nasal and the temporal hinges here, and the hinge position, the hinge angles, and the width of the hinge can be titrated. So these are the essential parameters which, when you're dealing with a femto-based platform, can be titrated vis-a-vis the microkeratome structure. There are certain essential benefits when you're doing a femtoflap. It basically gives you a good visualization of the stroma. So that means whenever you're doing, and once you have docked, you essentially see where you are cutting. So even if you have a suction breakdown, you can see at what level or what percentage of the cut has been, and then you can restart the treatment. You can customize the flap parameters. I'll be talking about this. So customization means you can actually vary. You can have a nasal or a superior hinge. You can, as I told, the diameters, the thickness, and the side cut angles can be customized. So the side cut angles can be customized. The flap thickness can be customized. The diameter and the centration can be customized. So sometimes for patients where there is an angle kappa you're talking about, you can actually slightly decenter, or you can make an oval. You can have the selection of the hinge and the flap orientation, and but this is the independent of the suction ring location. Now, when you are talking of the microkeratome vis-a-vis the femto, there are fewer flap-related complications, as in what we normally see in a microkeratome. A lot of chances of incomplete flap. You can have buttonholes, free flaps, irregular flaps, and the hinge position flexibility is one very important thing. And this ultimately boils down to epithelial, less chances of epithelial ingrowth. And when you talk of mechanical blades, sometimes you can have the malfunction because of the loss of the power. We have seen a lot of times the mechanical parts get jammed. There can be a loss of suction. You can have improper assembly when your assistant really makes your day hell. Clinically insignificant, but when you use a femtosecond laser system, so I mean, actually, all these complications boil down to a very low incidence when you're talking of the femto-based platform. Now, the hinge position flexibility is actually very important because you can customize the hinge position, because patients, when we are dealing with high regular astigmatism, you can actually have a superior hinge to have a deeper ablation, which is required in the 3 to 9 o'clock. Dry eye, a lot of studies have seen that they may benefit from nasal or a temporal hinge position due to decreased severing of the afferent nerve trunks. Hyperopic patients may benefit from the temporal hinge position due to the nasal angle kappa. So the femtosecond laser actually stands advantageous. And a lot of studies have shown a lower incidence of epithelial ingrowth, and this is essentially because of the side cut angle. So you can actually customize the side cut angle, and it is believed that with this actually locks the flap and the side cut, so which inhibits the passage of the epithelial cells into the interface. There is less variability in the flap thickness. So the standard deviation with the femtosecond is close to around 11 microns as compared to mechanical, which is close to around 14 microns. You can actually control the flap diameters and the hinge width. And it is found that the higher order aberrations when compared with the mechanical microkeratome is slightly less, and which suggests and translates into an improved visual outcome. It's not that this system doesn't have disadvantages. There are a lot of disadvantages which can occur. You can have opaque or the OBL, you can have vertical gas breakthrough, and you can have sometimes patient complaining of transient light sensitivity syndrome, which could last for a couple of days. You can have a high rate of DLK in patients, and definitely the higher cost which is involved for the purchase and the maintenance. A lot of studies worldwide which have compared, but all of these studies have basically essentially boiled down to the microkeratome based systems. So I'll just take a minute more. So all of these studies have essentially highlighted that most of these complications that occur in flap making are more with the microkeratome based as compared to the femtosecond, and essentially the free caps, the incomplete flaps, buttonholes, thin and thick flaps, irregular flaps, suction loss, essentially are more with the microkeratome based systems. So femtoflaps on the ASOCT, a lot of studies have said were more accurate, they were reproducible and uniform than those created by the microkeratome, though both the femtosecond and the microkeratome LASIK are quite effective and safe. So there's no statistically significant difference in the uncorrected and the corrected visual acuity, though the FS scores over microkeratome in terms of the predictability of the flap thickness and the fewer induced higher order abrasions and the better contrast and the longer tear breakup time. So when you talk of the ocular surface changes, the femtosecond laser allowed for a full recovery of the tear meniscus as compared to the microkeratome, which failed to reach the preoperative levels. So to conclude, the femtoflaps on the anterior segment OCT are more accurate, they are more reproducible, and they are more uniform than those created by the microkeratome, though the vision and there is no statistically significant difference in terms of the vision achieved. So a lot of references which I would like the people who are new to the system to read this, and a lot of literature and work has been done. So thank you very much.
Thank you, Dr. Sonu, for a very nice overview on the basics of what is FemtoLASIK. And we all understand that there's definite advantage of femtosecond laser in creating the flap, because the flap-related complications have really gone down. And in earlier generations, I think maybe OBL was an issue. These days, it's hardly an issue. A major issue is the cost. Microkeratome also does well, but in a large percentage of cases wherein you have a very steep cornea or a flat cornea, in such cases, there's definite advantage of femtosecond laser. And what I feel, although there's no comparative study to my knowledge, but I feel that the edge of the flap somehow also to some extent prevents the increased risk of epithelial ingrowth in these cases. So that's definitely there. Any comment or any, Dr. Ajay, can you please come up? Any comment or any addition to what Dr. Sonu has very nicely pointed out? Yes, sir.
I think there's improvement in every field, everywhere. Even microchrome has improved in between. We are now getting planar flaps, which are much comfortable, and we can have a overflap also. Of course, femtosecond has advantages, but these things are also improving.
Yeah, that's very true, sir. Very true.
But sir, I'll just like to interrupt in this. Actually, in your practice, you would have noted whenever you're treating patients who have actually a very flat cornea or a very steep cornea, when you take these patients on a femto platform, you're hardly concerned about the K readings. But actually, when you take these patients on a microkeratome-based system, you're actually very conscious that you might end up whether in a free flap or a buttonhole. So whatever the improvement might be, but still, you know, that kind of, some kind of dilemma in the mind always remains, and you are a little extra cautious. So I think it is these extreme of patients which are essentially very important when you're dealing in such subset. The only indication I still feel is those patients which have a scarred or a corneal opacity where the femtosecond actually cannot penetrate. So I think this is one essential indication I would, you know, boil down to microkeratome-based flap system.
Yeah. Very faint scar, it still works, but if it's a dense scar, it doesn't.
Thank you.